Thank you for the introduction and thank you for the title. It would take probably 2 days to start from COPD to get down to density of the lung. But here's the story. This is what we have when we do lung cancer screening, and this is what we would like to get to, both for functional reasons and for risk stratification. We heard about risk stratification a lot, but of course, people suffering from long-term chronic inflammatory disease are also suffering from functional disease. And we have heard about Professor Seyo yesterday, the comorbidome. If you remember those dots, yeah, the dots for chronic pulmonary disease were quite larger than lung cancer. So it's indeed important, and we have been going through the years trying to track these findings as a correlate to the anatomy and the function. So this is what we have, as we said, and we can stratify the percentage of emphysema, which could be a good correlate to the risk of COPD. It's not a diagnosis of COPD because we miss some functional and some clinical information, but this can be, again, a risk stratifier. We can do it visually, as you can see on the left-hand side, but or the same CT, you can quantify the density. Quantifying the density, the threshold, the optimized threshold proposed is minus 950. Hounsfield unit, and to normalize the extent of this area of such low attenuation, you do the percentage. So when you do the percentage, you kind of try and normalize this extent compared to the full volume of the lung. But that's actually just one variable that we have. We have many more variables here, and some of those variables are actually relying on technical representation, but also on anatomical representation. So first of all, technical variable is that we are using low-dose CT, the noise of which is actually higher than the full-dose CT that you see on this right-hand side. So if you could have this, we could be a bit more reliable. Even if you could have this one, which is micro CT, we could be even more reliable in the measurement of the density, but this is not what we have. So we can start from here, because here we have the anatomical references, and we can extrapolate what we think this other thing should be to get to that point. So we have an anatomical reference, and then we have something that we have to optimize. You've seen this slice being cut in two pieces. The left lung is now with what you want to look at as a radiologist, as a clinician, as a quality of the image. The right lower lobe is actually the one that you want to stratify the density of the lung into clusters or areas of low attenuation. We're now playing on the technical edge of the instrument that we are using, which is CT, and so these data need to be prepared for this specific task. So what we can do in our clinical practice, if you want, we can have a reconstruction for visual reading and a reconstruction for quantitative reading. This is actually what we do in our program in Parma. This is the one that you want to look at if you look at I-LAA or other things that go on in the lung beyond lung cancer. And this other one is the one that you look at for measuring nodules, measuring emphysema, and so on. So this solution can be based on the very reconstruction on your CT, or some vendors like the vendor that is proposing this solution, which is Coraline, and in this presentation that I'm given, they provide a normalization of these data towards this. This is an option, but actually it includes some variables in it. So we have not much control over that, so this is something that we have to dig into. So when we look at low area of attenuation in the lung with the threshold of 950 Hounsfield unit, we're therefore prone to some variables, as we said, and all of this is a function of the image noise, which depends on the radiation dose and also on the reconstruction filters that we can have on the scanner that we use. So we think that we are scanning people over the ears, and this is a functional information that we are chasing. So probably we would like to have this consistent through the ears and through the geography, but actually this is relatively uncontrolled across different acquisition and reconstruction protocol. And this is indeed the case of lung cancer screening, where you have 20 years of scanning, you might change your address being scanned here and there. So what could be one of the solutions to meet that problem? So what if we get back to the morphology, to the anatomical reference that we were saying before? We kind of get towards the relevant evaluation of those areas of emphysema. So we could think about not just thinking of all the percentages of small areas that are in the lung, but we take areas below that threshold at a minimum cluster size. So this could really bridge between the technical edge that we have and the morphological anatomical reference that we are aiming to. We remember the PFTs in the beginning and then the anatomy. This is what we would like to have, everything we would like to have with these very, very low dose images. So of course, it includes some reasoning and some complexity, some more methods, boundaries that we have to have along our pathway towards this abstraction of the quantitation of the emphysema in the lung. So what we did in this study that comes from the iDNA group and is examining CTs from the Nelson, so the Nelson and China BIG3 trial, it was decided to define a reference for the minimum cluster of the disease. So for each subject, you would have taken the largest cluster of low density minus 950 HU threshold for each subject. So that was the category the subject was falling into. So you have this size of largest cluster, you're in that category. If you have smaller ones, well, those don't actually count. Then to define a minimum cluster to be able to discriminate between noise and actual cluster of emphysema, it was noted that on those subjects with known or trace of emphysema as classified by Fleischner criteria by 3 readers, those clusters that were pigeonholed in this category were all those clusters below or until 5 millimeters. So cluster of emphysema with a diameter of 5 millimeters or less were excluded from the cluster analysis. And the cluster analysis was run for those clusters that were between 6 and 9 millimeters at 1 millimeter interval. So what are the results of this analysis? If you use cluster analysis across this range from 6 to 9 millimeters, you actually get an inverse association with the sensitivity. So the larger the cluster, the lower the sensitivity in detecting at least mild moderate emphysema or severe emphysema in these subjects. So the most sensitive category was the 6 millimeter cluster. But also in comparison to the percentage of area below minus 150, cluster analysis by 6 millimeter cluster showed a wider area under the curve of 0.97 as compared to almost 0.9 by LAA percentage. And this goes back to different data, the COPD Gini data, where the full dose CTs were used. They found that also in healthy volunteers, you could find a 2% extent of LAA percentage. So this probably explains this difference in accuracy, because there is some degree of noise when you examine those CTs, and also probably small bronchioles slightly dilated in the edge of the size of this, or what can be segmented. So if you use cluster analysis in contrast to LAA percentage, you are more accurate because you get rid of those noise boxes. So we're doing low dose, and noise is indeed a problem. So we might have a new solution, but yeah, new things are always so appealing, but we also have to think that there might be some issues also with this. So we need confirmation, we need validation. So if we think about cluster analysis and the size of the cluster, should we be thinking about variables associated with that? The depth of inspiration, again. It's been a long time problem with this kind of analysis. But also you can have overlapping diseases, which happen to be quite frequent in smokers, like those diseases that increase the density of the lung, which can be respiratory bronchiolitis, DIP, now better known as alveolar macrophage pneumonitis, or other kinds of actually interstitial abnormalities. Also with fibrotic changes that make it very difficult to interpret spirometry without carbon monoxide diffusion. And also, if we look forward, we don't really know how this kind of approach can be managed with more complex data such as the photon counting technology. But we're starting to look at morphology, we're starting to look at anatomy with this cluster analysis just beyond the density that we are so keen in. So we should not be forgetting that we get also much more anatomy references when you do a CT, and these are all debatable. You can say many things about this, but at the end of the day, if you think about COPD, these are also guys in the room. So the chest diameters and the ratio between chest diameters, the shape of the diaphragm, and we should not forget about vascular distribution within the lung, because COPD, emphysema, all these obstructive diseases together, actually they cause hypoxia, vasoconstriction in the lung. And if we can normalize the measurement of the vessels along with the clusters, that could be an extra information that could add up to that. Thank you for your attention.